Welcome back to episode 4 of Anatomy Basics and Chinese Medicine. This week we're going over the trunk and the shoulder girdle. Last time we talked about the spine, so if you haven't seen that video, please check it out. I'm linking it up here. And today we're starting with the trunk. So when we're looking at the front of the trunk, you can see in this image that we have the sternum bone in the front. We have the ribs on each side, 12 ribs to be exact on each side, which is a total of 24 ribs. And in the back of the body, the ribs connect to their respective thoracic vertebrae. So rib 1 attaches to T1, rib 2 to T2, 12th rib attaches to T12. When we're looking at the front and how the ribs attach to the sternum, the ribs attach via this cartilaginous tissue into the sternum bone. And we have 8 ribs in the front, or really 7 ribs in the front that are true ribs. 8th rib through 12th rib are false ribs because they don't attach directly to the sternum bone. They actually attach to the cartilage of the 7th rib into the sternum. And ribs 11 and 12 are actually floating ribs, so they don't attach to the sternum at all. They are simply connecting to the spine in the back and then are floating from the posterior aspect towards the anterior aspect of the body. The 12th rib being the shortest one, and sometimes it's even hard to palpate on people who have dense muscle tissue or thicker adipose tissue, aka the fatty tissue. Now, as far as the sternum bone goes, we have the topmost part, which is called the manubrium. Then we have the body of the sternum, and at the bottom we have the xiphoid process. On some people, the xiphoid process can be very long. On some people, it can be very short, and some people don't have it altogether. Now, when we do CPR, for instance, we need to be mindful when we're compressing the trunk not to break off the xiphoid process. From the sternum bone and going out laterally, we have this bone which is the collarbone or the clavicle. The clavicle articulates with the sternum bone via the sternoclavicular joint. Now, we also have the shoulder blade, which is on the back of the trunk, nicely connected to the rib cage, and the scapula is not connected to the rib cage as a true joint, unlike the ball and socket joint, our main shoulder joint. The scapula is simply gliding up and down and medially and laterally on the rib cage via the muscles that attach there. The true joint, the true shoulder joint, which is the main shoulder joint, is our gleno-humeral joint, and it is a ball and socket joint. Now, as far as the structures go, when we look at the scapula attaches to the clavicle, our collarbone, via the acromion process. So the joint that is there is the acromioclavicular joint. Acromion process is simply the extension or the protrusion from the spine of the scapula. So when we look at the scapula, our shoulder blade, we have the superior angle, inferior angle, we have the medial border, which is also called the vertebral border, and we have the lateral border further away from the midline, also known as the axillary border, which is closer to the axilla, aka the armpit. On that lateral aspect of the scapula, we have what is known as the glenoid fossa. Fossae are saucer-like indentation, and we have them over many different flat bones, including the scapula, including the hip bones. And we'll talk more about each of these fossae as we're going through the muscle attachment sites. So the glenoid fossa articulates with the upper arm bone, which is called the humerus. not a very funny bone, right? Especially when we hit the ulnar nerve right here on the medial aspect of our elbow. However, humerus is the upper arm bone which articulates with the glenoid fossa to create this ball and socket joint. And ball and socket joint, what that means is that it has all 5 movements through different planes of movement. If you are not familiar with the planes of movement, please visit the first video in this series where I go over all the planes of movement and directions of movement for each of the joints in the body. Now, the shoulder joint, because of its ball and socket shape, we have the head of the humeral bone, which is looking like a ball. Then we have the neck, and the neck can be at different angles depending on the structure of your body. Everyone is a little bit different. So some necks can be in this shape, some can be a little bit straighter, some can be at 90 degrees. The same goes for the hip joint, because the shoulder and the hip are very similar in its structure, except that the fossa of the shoulder joint is less stable, right? It's a smaller joint, it's less indented, but basically the head of the humerus articulates with this glenoid fossa via ligaments and tendons to keep this joint in place. So it looks something like this, and then that ball, the head of the humeral bone, can shift and rotate and circumduct, right? Circumduction is a multi-axial movement. When we're talking about the rest of the shoulder blade, I mentioned the spine of the shoulder blade. The spine of the shoulder blade, or the spine of the scapula, is located right here as you see it in the diagram, and it comes out and curves towards the anterior aspect of the body to articulate with the collarbone or the clavicle, like I already mentioned, and that is our AC joint, or acromioclavicular joint. The spaces above the spine of the scapula, below the spine of the scapula, and under the scapula are called fossae. So the space above the spine of the scapula is called supraspinous fossa. Supra being superior, above, spinous relating to the spine of the scapula, and fossae, or fossa, singular, is that saucer-like indentation I already mentioned. So above the spine of the scapula is supraspinous fossa. Below the spine, or under the spine, we have inferior. So inferior is someone that's below you in rank. Infraspinous fossa. So the space that is inferior to the spine of the scapula. And then underneath, thinking like what goes under the water, what vehicle goes under the water, is a submarine. So under the scapula is a subscapular fossa. That space, which is going to have a muscle attaching to it, is underneath the scapula. So those are some of the major attachment sites to muscles that we're going to cover in later videos. For the first portion of this series, I'm really focusing on bones and bony landmarks, things that you need to know before we get into the muscle and tendinous tissue. What connects bone to bone are ligaments. So ligaments connect bones to bones. Joints are basically where the bone articulate with another bone. So we have a shoulder joint, we have our hip joints, knee joints, ankle joints, wrist joints, etc. And all of these joints are different types of joints. So right now we covered the gleno-humeral joint, which is the main shoulder joint, and it's the type of joint called the ball and socket because it has all 5 types of movement. So on the front of the body, as you remember from our previous videos in this series, we have flexion of the shoulder. So when the arm is coming up towards the front and towards the ceiling, right, that is called flexion of the shoulder. When the arm is reaching back behind us towards the posterior aspect of the body, that is called extension of the shoulder. When the arm is reaching out to the side away from the midline, we call that abduction of the shoulder. When we bring the arm back towards the midline, we call that adduction, ADD, towards the midline, adduction of the shoulder. And then we have rotations, right? Internal rotation, external rotation, or here, internal rotation, external rotation. Here it would be internal, external. Now, sometimes people get confused with external and internal rotation depending on where the limb is in space. If you're confused, always go back to your anatomical position. What is the anatomical position? Like we covered week 1 or video 1 in this series. You're standing with your feet parallel, arms dangling by your sides, palms facing forward, right? So if I bring my arms up from the anatomical position like this, and my thumbs are facing out, this would be external shoulder rotation. If I reverse that, and I bring my arms into this position, going back through anatomical, my palms are not facing forward anymore, they're facing the back. So here in internal shoulder rotation. And my students get confused all the time here, so always go back to your anatomical position when you're unsure of whether it's a medial or lateral shoulder rotation, especially if you're a movement professional or looking to become a massage therapist or a yoga teacher, right? You will be guiding people in those positions in different planes of movement. So just know what is medial, what is lateral, so you understand if someone is having a struggle with a particular movement, then you'll also be able to identify, okay, which muscles are working, what are my medial rotators, what are my lateral rotator muscles, and how can I help this client based on what are their movement patterns or what they're having difficulty with, right? So that was about the main shoulder joint, which is the gleno-humeral joint. And now when we talk about the scapulothoracic joint, remember going back to the beginning of this video, the scapula is gliding up and down on the trunk, on the rib cage, on the thorax, laterally and medially, so out to the side and towards the midline. But there's also movement that is called downward and upward shoulder rotation, okay? So when that glenoid fossa, that lateral aspect of the scapula and the acromion process, when they're going up, like when we're reaching the arm up into abduction of the shoulder, that is also called upward scapular rotation. When the glenoid fossa and the acromion process are tilting downwards, when we're drawing the shoulder blade down like this, that is called downward scapular rotation. And we also have that movement that I said, lateral to medial, which is protraction and retraction. So when we're pushing the shoulder blades forward and we're rounding like this, that is called scapular protraction. When we're drawing the shoulder blades back in towards the midline of the body, towards the spine, that is called scapular retraction. We can also call movement away from the vertebrae scapular abduction, or scapular movement towards the spine or the vertebrae, scapular adduction. So these are all terms that we can use interchangeably. Scapular protraction or scapular abduction, scapular retraction or scapular adduction, ADD. Okay, we can also lift the shoulder blades up and down, like I said earlier, and we call that scapular elevation. Think when you're happy, elevated mood, right? Scapular elevation. And when we're sad and depressed, scapular depression, when the shoulder blades are going down the rib cage. Okay, so just to recap, on the front, we have the sternum bone, which the ribs, 12 ribs on each side of the body, 24 ribs total attached to the sternum bone. The first 7 ribs directly attached to the sternum bone. Ribs 8 through 10 are attaching to the sternum bone by attaching first to the cartilage of the 7th rib. And then the floating ribs, which are ribs 11 and 12, do not attach to the sternum bone. That's why they're called the floating ribs. So ribs 8 through 12 are basically false ribs because they don't attach to the sternum directly, and ribs 11 and 12 are the floating ribs. That's what we call them. And then as part of the sternum bone, we have the manubrium on the top, the body of the sternum, and the xiphoid process at the bottom. We have the clavicle attaching to the sternum via the sternoclavicular joint. The spine of the scapula has that protrusion or the process called the acromion process, which articulates with the clavicle. This is the acromioclavicular joint. And then the scapula itself articulates with the upper arm bone called the humerus to create the main shoulder joint, which is our gleno-humeral joint, because the head of the humerus articulates with that glenoid fossa on the lateral aspect of the scapula, creating this ball and socket joint. And then the spaces on the scapula itself, we have the superior angle. These are certain aspects of the scapula that we should look at, especially when trying to palpate a certain musculature on our clients. So superior angle, which is also level with T2 vertebrae. The spine of the scapula is level with T3 vertebrae, more or less, and we have the inferior border, which is level with T7 vertebrae. The medial aspect or medial border of the shoulder blade, also called the vertebral border, and the lateral aspect of the shoulder blade, also called the axillary border because it's closer to the axilla or the armpit. And then when it comes to the channels in Chinese medicine, traditional Chinese medicine, the channels that are running through the shoulder area, we will talk more about them in depth when we come to the muscle classes or videos. However, on the anterior aspect, what we have here is the large intestine channel. We also have the lung channel. On the lateral aspect, we have the sanjiao, or that triple heater, which belongs to the fire element. The large intestine and the lung meridians, they belong to the metal element. And on the posterior aspect of the shoulder or the shoulder girdle, we have the small intestine channel. And the small intestine channel can treat issues that have to deal with some of the insertions or attachment portions of the rotator cuff muscles. Especially a lot of people suffer from rotator cuff injuries, including the supraspinatus tendon and some other structures that, like I said, we will mention when we get to the muscle portion of this series. And as far as issues such as frozen shoulder, right, when people really can't reach the full extent of that range of motion, we can also treat it not just with local points, but there are distal points, especially relating to the kidney channel. So when there is a frozen shoulder aspect, we can also look at the kidney energy. Of course, treating locally through the large intestine, lung, sanjiao, and the small intestine channels can be very beneficial to address any issues in the shoulder girdle. Top of the shoulder especially, there's an amazing point that we can use acupressure on, which is called gallbladder 21, short for GB21. and that point is very downward bearing, right? So we need to be mindful, especially when we have pregnant clients, not to push down on that particular point. When it comes to neck issues, obviously that is more part of the spine class, but the muscles that are attaching to the trunk and going up to the neck and the skull can be treated with some of the local points on the neck and right below the occiput, right, the lowest portion of the back of the skull. So points like UB10, which is urinary bladder 10, points such as GB20, also releasing muscles such as the sternocleidomastoid. And there's so many different ways to treat imbalances in the neck and shoulder area, but locally it can be very beneficial when we're just using our hands, right? So using massage therapy or acupressure. Lots of points around the anterior aspect of the shoulder as well as the posterior aspect of the shoulder. So many different ways we can treat. And of course, cupping therapy is amazing for any issues with the shoulder because it brings the blood back to the surface of the tissue, increases blood flow and new cells in the area, and alleviates pain and tension. If you haven't seen any of my cupping videos, please check them out. I have several cupping videos already created for you. Some are older, the audio and video is not the best, but the information is invaluable. And I also have some self-treatment cupping videos that you can also check out and help yourself if you're experiencing any neck and shoulder tension. I actually woke up yesterday with a little bit of a creaky neck on the right side, and I immediately started doing some PNF stretches, and I applied cupping therapy, and today I feel much better. I am back to my normal range of motion without any pain and discomfort. I hope this is very helpful for you, and if so, please leave it in the comments below. Share these videos with your loved ones and anyone that you think may benefit from this type of information. And as always, please subscribe. It really helps the channel grow, and it gives me an idea that I should keep going with these videos because I love teaching and I love sharing what I know. And I'll see you in the next one. Have a fantastic week ahead.